Welcome to the Deep Dive, the show where we really get into the sources, the research, the articles, the notes, to bring you the essential insights, maybe some surprising facts, and enough context so you feel properly informed, but, not swamped in technical terms.
Exactly.
Today, we are tackling something that crops up far too often, particularly if you're involved in sports in any way. Injuries to the anterior cruciate ligament, that infamous ACL tear.
It's a really significant problem, actually, and quite complex when you look closely.
Yeah.
The sources we've drawn on top orthopedic resources like OrthoBullets, OrthoInfo, StatPearls, the Bone School, they give us a pretty detailed picture. From the tiny fibers of the ligament itself right through to the, often long road to recovery.
Absolutely. So our aim here is to guide you, our listener, through what these resources tell us about ACL injuries. We'll look at what the ACL actually is, how these tears usually happen, how doctors work out what's gone wrong, the treatment choices, what recovery involves, and, the potential bumps in the road. It's a proper deep dive into a major knee issue.
Right. Let's get started then. See what the sources lay out for us.
Okay, starting right at the beginning. When we talk about the ACL, what exactly is it? Whereabouts in the knee does it live, and what's its job? We know the knee is where those big leg bones meet, don't we?
That's the place to start, yes. The knee joint, it's essentially where three bones come together. You've got the femur, the thigh bone coming down,
Right.
the tibia, the shin bone below it, and then the patella, the kneecap, sitting at the front there. And holding these together, giving stability, are strong bands called ligaments. Think of them like, really tough ropes.
Ropes providing stability.
Okay.
And the knee relies on several of these.
It does. Four main ones. You've got the collateral ligaments running down the sides, the medial collateral, the MCL on the inside,
Side. Okay.
and the lateral collateral, the LCL, on the outside. They primarily stop the knee bending sideways, buckling inwards or outwards.
Got it. Side-to-side stability from those. And then there are the ones inside the joint crossing over.
Precisely. Those are the cruciate ligaments. They form an X shape right in the center of the knee. There's the posterior cruciate ligament, the PCL, towards the back, and the anterior cruciate ligament, the ACL, at the front. And these two are really crucial for controlling the forward and backward movement of the tibia relative to the femur.
And our focus today, the ACL. Where is it within that X, and what are its main functions according to these sources?
So the ACL runs diagonally right through the middle of that joint space. Its role is absolutely fundamental for knee stability. The sources really flag up two key jobs. First, stopping the tibia from sliding too far forward relative to the femur.
All right, that forward slide.
And second, providing rotational stability. That's vital for any twisting, pivoting, changing direction type movements. It's not huge, actually usually about 32 millimeters long, maybe 7 to 12 millimeters wide.
So it's not just stopping that shin bone shifting forwards, but also controlling the twisting. That rotational part sounds critical for anything dynamic.
Oh, absolutely. It's crucial. And the sources, they actually break the ACL down further. They talk about its two main parts, or bundles, the anteromedial bundle, the AM, and the posterolateral bundle, the PL.
Two parts doing slightly different jobs. Tell me more about that.
Yes, they have subtly different roles, and they get tight at different points in the knee's movement. The AM bundle is described as being more isometric, meaning its length doesn't change that much as the knee bends and straightens. It's tightest when the knee is bent in flexion.
Okay.
And its main job is resisting that straightforward movement of the tibia. It gives about 85% of that anterior stability.
The main stabilizer for forward movement?
Largely, yes. The PL bundle, on the other hand, changes length more. It's tightest when the knee is straight in extension, and it's primarily responsible for controlling that rotational stability we mentioned.
That's fascinating. So perhaps if someone has a partial tear, which bundle is affected could influence the specific type of instability they feel.
That's exactly right. Although it's worth noting, the sources say most ACL injuries are complete or very near complete tears, but partial tears do happen. The ligament itself, it's mostly type I collagen that gives it its strength. It gets blood supply from the middle geniculate artery and has some nerve endings too. It's remarkably strong. Actually, it can withstand forces around 2,200 newtons.
That sounds like a lot.
It is significant, yes. But clearly, under certain conditions, particularly in sports, the forces can exceed that.
Right, which brings us neatly to the next point. How does this strong ligament actually get torn? What are the typical scenarios that lead to an ACL injury?
The sources are very consistent here. The most common mechanism by far is what's known as a non-contact pivoting injury.
Non-contact, so it doesn't have to involve a collision or being tackled.
Correct. In most cases, no one touches the person. It usually happens when the foot is firmly planted on the ground and the body twists or pivots forcefully over the slightly bent knee. Often, the knee collapses inwards, what we call a valgus position.
Ah, I can picture that. The foot stays put, the body turns, and the knee caves in.
Precisely. The tibia is essentially forced forwards relative to the femur, often with that twisting element, and the ACL just can't handle that load.
That valgus collapse seems to be a recurring theme in sports injuries.
It is indeed. Other common non-contact ways it can happen include stopping very suddenly when running, slowing down rapidly, or landing awkwardly from a jump. Direct contact, like a tackle in rugby or football, can definitely cause an ACL tear too, often along with other ligament damage, but it's less frequent than the non-contact type.
And certain sports are just inherently riskier because they involve these movements constantly.
Absolutely. Sports like football, basketball, skiing, netball, they're frequently mentioned because they demand so many rapid changes of direction, cutting maneuvers, jumping, landing, sudden stops. The courses also suggest the rise in ACL injuries might be partly linked to more people participating in high-level, high-intensity sports.
Okay, so that non-contact pivot is the primary culprit. Now let's think about who gets these injuries. Is it mainly professional athletes?
Well, it's surprisingly common across the active population, not just pros. The sources quote figures like around 400,000 ACL reconstructions happening each year in the U.S. alone. They actually account for about half of all knee injuries treated surgically. The overall rate is about 1 in 3,500 people per year in the U.S.
Wow, that's a lot.
It is. And while it can happen to anyone, any age, the sources consistently highlight a much higher incidence among female athletes.
That's a really important point. Female athletes are often cited as being more susceptible. What sort of difference are we talking about, and what reasons do the sources give?
The ratio mentioned is quite stark. Roughly 4.5 female athletes injure their ACL for every one male athlete playing similar sports, so a significantly higher risk.
4.5 times higher. That's huge.
It is. And interestingly, the sources also mention female athletes tend to get these injuries younger, and often it's the supporting leg that goes, whereas males might more often injure their kicking leg.
Okay, so why? What's behind this disparity? What factors contribute to female athletes being at greater risk?
The sources suggest it's not one single thing, but rather a combination of factors. It's multifactorial. They point to differences in physical conditioning, overall muscle strength, and perhaps crucially, neuromuscular control.
Neuromuscular control. Can you unpack that a bit? What does that mean in this context?
It's essentially how the brain coordinates muscle activity during movement, particularly during dynamic actions like landing from a jump or quickly changing direction. The sources suggest female athletes may be more prone to landing or cutting with increased valgus at the knee, that inward collapse we mentioned, potentially combined with less bending at the hip and knee to absorb the shock.
So the way they land and move puts more stress on the knee joint itself.
Potentially, yes. They might also exhibit this valgus pattern more when fatigued, possibly due to differences in muscle fatigue resistance. Another key point raised is about muscle activation patterns. Some research suggests female athletes can be more quadriceps dominant.
Meaning they rely more on the front thigh muscles?
Exactly. They might engage their quads more heavily during deceleration or landing. The issue is, the hamstrings, the muscles at the back of the thigh, are actually more effective at preventing the tibia from sliding forward, which is what protects the ACL. Over-reliance on the quads during these movements might place abnormal stress on the ligament. Weaker core stability compared to males is also sometimes mentioned, as it affects overall control.
Okay, so it's about how the muscles fire and control movement and how forces are absorbed. Are there physical or anatomical differences discussed too?
Yes, anatomical factors are also suggested as potential contributors, though these are obviously less easy to modify. Things like possibly increased BMI, having a narrower space in the femur where the ACL sits the femoral notch, perhaps a smaller ACL ligament overall, or greater general joint flexibility or laxity.
And wasn't there mention of hormones as well?
Yes, the sources do touch upon potential hormonal influences, but they are careful to state this is still a somewhat controversial area, without definitive proof. The idea is that fluctuations in hormones like estrogen might affect the properties of ligaments. There's also a suggestion that coordination could be subtly affected during certain phases of the menstrual cycle, like the preovulatory phase. Interestingly, one study noted athletes using oral contraceptives seemed less affected, but again, it's complex.
So a potential factor, but the jury's still out on the exact role of hormones. Anything else that increases risk?
Genetics might play a part. Variations in genes related to collagen, like COL5A1, have been linked to injury risk. And other general risk factors include having had a previous concussion, which could affect balance and reaction times, and unsurprisingly, having had a previous ACL injury on either knee significantly raises your risk of having another one.
That's a really thorough overview of the risk factors, showing just how complex this issue is, particularly for female athletes. Now, when the ACL does tear, it often doesn't happen in isolation, does it? Other structures in the knee frequently get damaged simultaneously.
That's a critical point the sources emphasize. About half of all ACL tears involve damage to other parts of the knee as well. In acute injuries, meaning recent ones, damage to the lateral meniscus, the cartilage on the outside of the knee is very common. One source puts it at 54% of cases.
Over half.
Yes. And injuries to the PCL, the LCL, or the structures in the back outer corner of the knee, the posterolateral corner, can also occur at the same time.
And what happens if an ACL tear isn't addressed, if the knee remains unstable over the long term?
The sources are quite clear on this. A knee that's chronically deficient in its ACL is highly prone to progressive damage. This often involves chondral injuries, damage to the smooth articular cartilage that lines the joint surfaces, and more complex meniscal tears developing over time. Things like those difficult-to-repair bucket handle tears of the medial meniscus become more common in chronically unstable knees.
So living with that instability isn't just inconvenient, it actually increases the risk of more permanent joint damage down the line.
Precisely. It significantly increases the risk of developing further problems, including the earlier onset of osteoarthritis.
That really underlines why getting a proper diagnosis and appropriate management is so important. Okay, let's switch focus now to actually recognizing and diagnosing an ACL tear. What does it typically feel like for the person at the moment it happens?
The sources paint a pretty consistent picture of the immediate experience. A very common report is hearing or feeling a sudden, distinct pop sound or sensation from within the knee right at the moment of injury.
The classic pop. Often hear about that.
Yes, it's mentioned frequently. After the pop, patients often describe a feeling of the knee instantly giving way or buckling under them. Then comes the pain, usually felt deep inside the joint. In the majority of cases, around 70%, according to one source, there's significant and rapid swelling.
Why does it swell up so quickly?
That's due to bleeding inside the joint from the torn ligament fibers. It's called hemarthrosis. It's a strong sign that a significant injury has occurred within the joint capsule. Other common symptoms include difficulty putting weight on the leg, a more general ache around the knee, that persistent feeling of instability, especially when trying to cut or pivot, loss of the full range of knee movement, and tenderness if you press along the joint line.
Okay, so that combination, pop, giving way, pain, and fast swelling. Those are the big initial clues. But I've heard sometimes the initial pain and swelling can actually subside after a while.
They can, yes, and this is a really crucial point the sources make. The acute pain and swelling might settle down after a few days or weeks, especially with rest. However, the underlying mechanical problem, the instability from the torn ligament, is still there.
Right.
If the person then tries to return to sports or activities involving cutting and pivoting, the knee is very likely to feel unstable and give way again. And it's these repeated episodes of instability, this buckling, that puts the meniscus and the articular cartilage at such high risk of further damage, that progressive wear and tear we talked about.
So even if it feels a bit better, the instability remains, potentially causing more harm over time if you try to push through it.
Got it. How do doctors then confirm it is an ACL tear and figure out the full picture of the damage?
The diagnostic process really starts with listening carefully to the patient's story. How exactly did the injury happen? What did they feel? Could they walk afterwards? That history is key. Then comes a physical examination, which is absolutely vital.
And comparing to the good knee is important. Always. Comparing the injured knee to the uninjured one is essential to establish the person's baseline level of laxity, as everyone's different. Doctors will look for swelling, check for things like a quadriceps avoidance gait, where the patient subconsciously avoids fully straightening the knee, and assess for any pre-existing alignment issues. They'll also perform specific tests for associated injuries, like meniscal tears or damage to other ligaments. A lack of full knee extension is a particularly important finding, as it might signal a trapped piece of meniscus or early stiffness setting in.
And there are those specific hands-on tests for the ACL itself, provocative tests. Which ones are the mainstays?
Yes. The Lachman's test is widely considered one of the most sensitive and reliable tests, especially soon after the injury.
How does that one work?
The examiner has the patient lying down, knee bent slightly, usually around 30 degrees. They stabilize the thigh bone with one hand and gently pull the shin bone forward with the other. In an ACL tear, you'll often feel the shin bone move forward more than on the uninjured side. And crucially, you won't feel a distinct, firm stop, what we call the end point. It feels sort of mushy or empty.
Looking for that excessive forward slide and the lack of a solid stop.
Exactly. The sources give it high accuracy ratings, around 95% sensitivity and 94% specificity. The amount of forward movement helps grade the tear, and comparing sides is absolutely key.
Makes sense. What about the anterior drawer test? Is that similar?
It's another common one, yes. For this, the knee is bent more to 90 degrees, usually with the foot resting flat. The examiner sits lightly on the foot and pulls the top of the shin bone forward. Again, excessive forward movement compared to the other side suggests an ACL tear. Interestingly, the sources note this test is often more reliable or easier to interpret in chronic ACL tears, perhaps when the initial pain and muscle spasm have subsided.
Right, so Lachman's may be better acutely, anterior drawer potentially more obvious later on, and the pivot shift test. That sounds like it's deliberately trying to make the knee feel unstable.
It is, in a controlled way. It aims to replicate that giving way sensation the patient might describe. The examiner takes the knee from a straight position, applying a bit of inward pressure, valgus, and internal rotation to the lower leg, and then bends the knee. If the ACL is torn, the tibia might start slightly forward when straight and then noticeably clunk or shift back into place as the knee bends to around 20-30 degrees.
So you're basically inducing that little subluxation and reduction to see if it happens.
That's the idea. However, it can be quite difficult to get a positive pivot shift test in someone who's awake and apprehensive or in pain, as muscle guarding can prevent the shift. It's often much easier to demonstrate under anesthesia when the muscles are fully relaxed. Because of this, the sources say it's highly specific. If you get a positive test, it's almost certainly an ACL tear, 98% specificity, but not very sensitive, maybe only 24% in the clinic, because it's often negative even when a tear is present.
That explains why it's not always positive, even with a definite tear. Are there any other, maybe simpler tests mentioned?
Yes, the sources mention the lever sign test. The examiner puts their fist under the patient's upper calf and pushes down on the thigh. If the ACL is intact, the heel should lift off the couch. If it's torn, the heel tends to stay down. There are also devices, like the KT1000 arthrometer, which can provide an objective measurement of that anterior tibial translation, quantifying the laxity.
Okay, so a combination of the story, the general exam, and these specific tests usually gives a strong indication. What about imaging? X-rays can't see ligaments directly, can they?
No, that's right. Standard X-rays mainly show bone. They're important initially to rule out any fractures associated with the injury, or to see signs like significant joint swelling. The ACL itself won't show up. However, X-rays can reveal subtle signs that are highly suggestive of an ACL tear.
Such as, what sort of clues might you see on an X-ray?
A classic sign is the second fracture. It's a tiny chip of bone pulled off the outer edge of the top of the tibia, near where another ligament, the anterolateral ligament, attaches. The sources state this finding is almost pathognomonic, meaning it strongly indicates an ACL tear, present in 75% to 100% of cases where it's seen.
Wow, so that little fleck of bone is a massive clue.
It really is. Other X-ray findings might include a similar fracture off the fibula head, an arcuate fracture, a depression on the outer part of the femur's lower end, a deep sulcus sign, obvious joint effusion or swelling, or, particularly in children, and a avulsion fracture where the ACL has pulled a piece of the tibial spine bone off with it.
So even without seeing the ligament, X-rays provide crucial indirect evidence. But to actually visualize the ACL and check for damage to meniscus or cartilage, MRI is the key tool, isn't it?
Correct. Magnetic resonance imaging, MRI, is considered the primary imaging modality. It's used to confirm the ACL tear diagnosis and, very importantly, to evaluate all the other structures within the knee, the menisci, the articular cartilage, the other ligaments. While a good clinical exam can often diagnose an ACL tear reliably, the MRI gives that detailed map of any associated damage, which is vital for planning the right treatment.
And how accurate is MRI for spotting ACL tears?
Very accurate. The sources typically quote sensitivity between 86% and 97%, and specificity correctly identifying when it's not torn between 95% and 100%.
What does a torn ACL actually look like on the scan?
Well, a normal ACL usually appears as a continuous dark band on the MRI images, particularly the sagittal views looking from the side. When it's torn, you might see a clear break in those fibers, or the ligament might look wavy, thickened, or have increased signal within it, making it look brighter on certain sequences. Sometimes it's just not clearly visualized where it should be, or its angle looks abnormal compared to bony landmarks like Blumensaat's line. On coronal views from the front, You might see discontinuity or just fluid signal in the space where the ACL should be sometimes called the empty notch sign.
So looking for disruption, abnormal signal, or just absence of the normal structure, are there other signs on MRI like that bone bruising you mentioned?
Yes, bone bruising is a very common secondary finding in acute tears, seen in more than half of cases. These show up as areas of edema or fluid signal within the bone marrow, typically in characteristic spots: the middle part of the lateral femoral condyle and the back part of the lateral tibial plateau. It's thought these bruises reflect the impact forces during the injury.
And they might have longer-term implications?
Possibly. The sources mention these bone bruises can sometimes persist for years and might contribute to the later development of osteoarthritis. Other secondary MRI signs could include visible damage to the MCL or objective measurement of more than 7 millimeters of anterior tibial shift on the sagittal view.
That bone bruising idea potentially linking to later arthritis is sobering. What about CT scans? Are they useful for diagnosing ACL tears?
Generally, no, not for the initial diagnosis of the ACL tear itself. CT is much better at looking at bone detail than soft tissues like ligaments. However, the sources highlight that CT scans become very valuable in the revision setting.
When a previous reconstruction has failed.
Exactly. If someone needs surgery because a previous ACL graft hasn't worked, a CT scan is the best test to accurately assess the condition of the bone tunnels created during the first surgery. It can show if the tunnels have widened significantly or if there's bone loss, which is critical information for planning the revision operation.
Okay, so MRI for the initial soft tissue picture, X-rays for bony clues, and CT, mainly for revision surgery planning. Is looking inside with a camera, arthroscopy, ever used just for diagnosis?
Yes, knee arthroscopy keyhole surgery allows the surgeon to directly look at the ACL and confirm if it's torn, and whether it's a partial or complete tear. This is often done as the first step of the actual reconstruction surgery anyway.
And injecting dye, arthrography.
Arthrography is mentioned as being highly accurate, technically the gold standard for sensitivity and specificity in some older literature. But because it's invasive, involving an injection into the joint, it's very rarely used nowadays as a primary diagnostic tool when MRI is so effective and non-invasive.
Right, so usually it's the clinical exam plus the MRI that gives the definitive answer and maps out the damage. Okay, let's move into section 3, the big decision point, managing the injury. To operate or not to operate? What guides this decision according to the sources?
The sources really stress that it has to be an individualized approach. There's no single right answer that fits everyone. The best course of action depends heavily on the specific patient, their age, how active they are, what demands they place on their knee in daily life or sports, whether there are other injuries in the knee, like a meniscus tear. All these factors come into play.
So surgery isn't automatically required for every ACL tear. When might a non-operative approach be suitable?
Non-operative management, which focuses on physiotherapy and potentially changing activities, is suggested as an option for certain groups. This might include older patients with low physical demands who aren't involved in pivoting sports, or perhaps recreational athletes who are happy to stick to straight-line activities like cycling or swimming. It might also be considered for some partial ACL tears, especially in adolescents where these are more common, if the knee feels stable and tests like Lachman's are near normal. And in young children with isolated tears, if they are low demand and can reliably avoid risky activities, a trial of non-operative treatment might be used to delay surgery until they're closer to skeletal maturity to protect their growth plates.
What does that non-operative treatment typically involve?
It usually starts with managing the acute symptoms, the RICE protocol: rest, ice, compression, elevation, settle, pain, and swelling. Then the core is a dedicated physiotherapy program, often lasting 3 months or more. This focuses on regaining full knee range of motion, strengthening all the muscles around the knee and hip, quads, hamstrings, glutes, core muscles, and working on balance and neuromuscular control. Regular follow-up with a clinician is important to monitor progress and stability. Interestingly, the sources mention that functional knee braces don't seem to offer any significant added stability for people managing non-operatively.
Right, the brace might feel supportive, but doesn't stop the underlying instability. You mentioned trying to delay surgery in children. What are the potential downsides or risks of not having surgery, particularly for younger, active people who want to get back to sport?
This is where the significant drawbacks of non-operative management become clear, especially if it's applied to the wrong patient group, like active young people. The sources point to research, like a study by Akroff, which followed children with ACL tears treated without surgery. The outcomes were concerning. They found high rates of ongoing severe instability, poor knee function, and crucially, a very high incidence of secondary damage occurring over time.
What sort of secondary damage did that study find?
In that particular study, out of 23 children treated non-operatively, 15 developed new meniscus tears, 3 suffered osteochondral fractures involving cartilage and bone, and 10 showed early signs of osteoarthritis. This really supports the understanding that those repeated giving way episodes, the buckling due to instability, place cumulative stress on the other structures in the knee, leading to progressive damage.
So those instability episodes aren't just inconvenient, they're actively harming the joint over time.
Exactly. The sources stress this risk of further meniscus and cartilage injury is particularly high if the person participates in what are called level 1 or 2 activities, basically anything involving jumping, cutting, pivoting, side-to-side movements, or heavy physical labor. So while delaying surgery in very young children to protect growth is a consideration, the sources imply that if the child simply cannot avoid these activities or the knee remains functionally unstable, the risk of causing irreversible secondary joint damage might actually outweigh the risks associated with modern growth plate sparing surgical techniques.
That really highlights the challenging balance in treating children and adolescents. So, given those risks associated with ongoing instability, when is operative management, typically ACL reconstruction, the recommended path?
ACL reconstruction, replacing the torn ligament with a graft, is generally indicated for complete ACL tears, particularly in younger, more active individuals. The evidence suggests reconstruction significantly lowers the risk of developing those secondary meniscus tears and cartilage damage down the line. For an active child or adolescent with a complete tear, realistically limiting their activity sufficiently to avoid risk is often very difficult, making surgery a common recommendation. It's also recommended for older patients, even over 40, if they remain highly active or have jobs with significant physical demands. Age itself isn't necessarily a barrier if the functional need is there.
So, it's more about the knee's required function than just the patient's age.
Precisely. Other indications include partial tears that still cause significant clinical instability and functional problems, or cases where non-operative treatment has been tried but failed, with instability persisting. If there's an associated meniscus tear that needs surgical repair, particularly if it's blocking knee movement, the ACL is often reconstructed at the same time. A really critical point mentioned repeatedly is that unless a meniscus tear is blocking motion, the patient must regain full range of motion before surgery. Operating on a stiff knee dramatically increases the risk of problematic postoperative stiffness or arthrofibrosis. And naturally, if a previous ACL reconstruction has failed, then revision surgery is indicated.
Okay, so reconstruction is generally for active people needing a stable knee for dynamic activities, aiming to restore function and prevent further joint damage. The sources also mention something important about return to sport, not just being about the physical repair.
Yes, that's a key insight. Success after surgery isn't judged solely on the stability of the knee. The sources highlight that successful return to play is influenced by a whole mix of factors: physical recovery benchmarks, performance on functional tests, demographic factors, and, significantly, psychological readiness, things like confidence in the knee and fear of re-injury. It underscores that recovery is a holistic process.
Understood. Let's move into section 4 then and get into the specifics of the surgery itself. Generally speaking, how is an ACL reconstruction carried out?
The standard method nowadays is arthroscopic assisted. It's keyhole surgery. The surgeon makes a few small incisions around the knee to insert a small camera, the arthroscope, and specialized thin instruments. They prepare the inside of the joint, clearing away the torn remnants of the original ACL to get good views of the bony landmarks. Although the sources do note there's no clear evidence showing a difference in outcome, whether you remove all a remnant or leave a small stump behind, which some believe might aid healing or proprioception.
And you mentioned earlier the ACL has those two bundles, AM and PL. Do surgeons typically try to recreate both?
Anatomically, yes, it has two main bundles. However, the most common surgical technique remains single bundle reconstruction, where one graft is positioned to replicate the function of both bundles. While double bundle reconstruction, using two separate grafts, might theoretically restore the knee's natural mechanics more closely and perhaps reduce laxity slightly more, the sources state that currently, studies haven't shown significant differences in patient-reported outcomes between the two techniques.
So the single bundle approach is standard and generally provides good results for patients. Once the graft tissue is ready, how is it actually positioned and secured inside the knee?
The graft needs to be passed through bone tunnels drilled in the tibia and the femur, spanning the joint, and then firmly fixed at both ends. There's a mention of preconditioning the graft, applying some gentle tension to it before final fixation, which might reduce some of the initial stretching or creep that happens after surgery. How much tension to apply during fixation seems less critical. One high-level study cited found no difference in outcomes between using 20 or 40 newtons of tension. The graft is usually fixed with the knee held in about 20 to 30 degrees of flexion.
And how do they actually anchor it? What are the fixation devices used?
There are quite a few options, and the choice often depends on the type of graft being used, e.g., bone plugs versus soft tissue, and surgeon preference. Common methods include interference screws. These are screwed into the tunnel alongside the graft, wedging it tightly against the bone wall. Another major category is suspensory fixation, like cortical buttons, where the graft is essentially hung from a small button resting on the outer surface of the bone. Other devices like screw and washer posts or staples are also used. Sometimes a combination methods is employed for extra security.
Okay, so screws, buttons, various ways to lock the new ligament in place. The sources seem to really emphasize that exactly where those bone tunnels are drilled is incredibly important for success. Why is tunnel placement so critical?
It's paramount. Tunnel placement dictates the position and angle of the new graft within the joint. The goal is to place the tunnels, and therefore the graft, as close as possible to the location of the original ACL. This is essential not just for restoring the straightforward anterior stability, but crucially for restoring rotational stability as well. Getting the tunnels drilled in a non-anatomical position is cited as the single most common technical error leading to graft failure.
So precision aiming is absolutely key. What are the guiding principles for getting those tunnels in the right spot?
For the femoral tunnel in the thigh bone, the surgeon needs to place it correctly both side to side, coronally, and front to back, sagittally. Placing it too vertically fails to control rotation effectively. Placing it too far forward can make the knee feel tight in bending, but loose when straight. Placing it too far back risks breaking through the back wall of the bone. Different drilling techniques exist transscibial versus using separate portals, but the sources suggest no major outcome differences as long as the final placement is anatomical. Drilling this tunnel with the knee significantly bent helps prevent that posterior wall blowout. For the tibial tunnel in the shin bone, its position relative to the remaining PCL and other landmarks is crucial. If it's too far forward, the graft can impinge on the roof of the joint when the knee straightens. If it's too far back, it might impinge on the PCL. The angle it's drilled at is also important.
It sounds like navigating those tunnels requires extreme precision. You also mentioned earlier that ACL repair, fixing the original ligament, is seeing some renewed interest. How does that differ from reconstruction, and when might it be considered?
Yes, repair involves attempting to reattach the patient's own torn ACL rather than replacing it entirely with a graft. Historically, ACL repairs had very high failure rates, which led to reconstruction becoming the standard. However, there's definitely been a resurgence of interest recently, particularly for very specific types of tears and potentially in children.
What kind of specific tears might be suitable for repair, according to the sources?
The main indication mentioned is for ACL avulsion injuries. This is where the ligament itself is largely intact, but has been pulled off its bony attachment, either on the femur or the tibia, sometimes taking a piece of bone with it. It's not generally considered for tears within the main substance of the ligament itself. In adolescents nearing skeletal maturity, certain repair techniques using suture anchors or suspensory fixation might offer a way to restore stability with potentially less risk to the growth plate compared to drilling large tunnels for a reconstruction graft.
And are the outcomes improving with these newer repair methods?
It's an evolving field. The sources acknowledge the poor historical results, but note that newer techniques, sometimes combined with biological augmentation scaffolds like the Bear implant trial, are being investigated and showing some promising early results in specific patient groups, with comparable outcomes to reconstruction reported at the 2-year mark in some studies. But it's not yet mainstream for most ACL tears.
Interesting. One to watch, perhaps. What about the situation where a previous ACL reconstruction has failed? That requires a revision surgery you mentioned.
Yes, ACL revision reconstruction is necessary when the initial graft fails and the patient is experiencing unacceptable instability during their desired activities. It's typically a more complex operation than the first-time surgery.
What makes revision surgery more challenging?
Several things. Firstly, the surgeon needs to figure out why the first one failed. Was it a technical error like tunnel malposition? Was a graft choice inappropriate? Did the fixation fail? Was there an undiagnosed associated injury putting extra stress on the graft? Or did the patient re-injure it? Secondly, the bone tunnels from the first surgery are often enlarged or maybe positioned non-anatomically, which complicates drilling new tunnels correctly. Thirdly, graft choice becomes more critical. The sources generally recommend using high-strength grafts for revisions. Often autografts like quadriceps, tendon, or hamstring is available, or sometimes allograft, donor tissue. Reharvesting a BPTB graft from the same knee is usually advised against. Because the bone quality might be compromised, surgeons often use enhanced fixation methods, perhaps dual fixation points. If the old tunnels are very large, say over 50 millimeter, or interfere with placing new tunnels anatomically, the revision might need to be staged. First surgery to bone graft the old tunnels, then a second surgery months later to do the reconstruction. There's also some debate about adding procedures, like a lateral extraarticular tenodesis, LET, in revision cases, particularly in young, high-risk patients, to provide extra rotational control, though its routine use is still controversial. Rehab after revision is often more cautious, too.
So revision is definitely a step up in complexity, requiring careful investigation and planning. Let's revisit graft selection for primary reconstructions. You outlined a few options: BPTB, hamstring, quad tendon, allograft. Can you summarize the key pros and cons the sources highlight for each?
Certainly. This is a really important discussion because the graft choice impacts things like recovery, potential complications like pain, and maybe even long-term outcomes or re-rupture risk. Autografts using the patient's own tissue have the biological advantage of faster incorporation, no immune reaction, and no disease transmission risk. The downside is you have to harvest it from somewhere, creating morbidity at the donor site.
Let's start with the bone patellar tendon bone, BPTB, often called the gold standard.
It's frequently referred to that way, yes, partly due to its long track record of successful use, especially in high-level athletes. The main pro is that it provides bone plugs at each end, allowing for bone-to-bone healing within the tunnels, which is thought to be faster and potentially more rigid early on. It's also a very strong graft. The major con cited consistently is a higher incidence of anterior knee pain at the front of the knee, particularly when kneeling. This is reported in 10–30% of patients. Rare complications include patellar fracture or patellar tendon rupture. There's also a note about potentially higher re-rupture risk if used in very young patients, under 20, or if the graft harvested is less than 8 millimeters wide.
So strong and reliable fixation, but potential for harvest site pain. What about the hamstring autograft? That seems incredibly common now.
It is, yes. Typically, two tendons, semitendinosus and gracilis, are harvested and folded over to create a four-strand graft. The main advantages are usually a smaller incision, less pain immediately after surgery, and significantly less anterior knee pain compared to BPTB. It's also mechanically very strong, often stronger than BPTB in lab testing. Potential downsides include a theoretical concern about residual hamstring weakness, especially peak flexion strength, although the functional impact is debated. Some sources raise a question about whether this weakness, particularly in females, could slightly increase re-rupture risk, but again, that's not definitively proven.
Is that hamstring weakness usually noticeable long term?
It can be measurable, but whether it affects function significantly varies. Other potential complications include nerve irritation near the harvest site, causing numbness, paresthesia, though certain incision techniques might reduce this risk. Also, because hamstring grafts are typically fixed with suspensory devices like buttons, there's the potential for a windshield wiper or bungee cord effect, where the graft moves slightly within the tunnels, which might lead to some tunnel widening over time, though the clinical relevance of this is also debated.
That windshield wiper image is quite descriptive. How about the quadriceps tendon autograft? Is that becoming more popular?
It seems to be gaining traction, yes. It can be harvested just as soft tissue or with a bone block from the top of the patella. Key advantages include the harvest incision being away from the area you kneel on, which is beneficial for some patients. If harvested without the bone block, it avoids crossing the growth plate in the tibia, making it a potentially good option for skeletally immature patients compared to BPTB. Its strength is good, comparable to the native ACL, and patient outcomes seem similar to other autografts. It's also often available as a virgin graft option for revision surgeries. Disadvantages are similar to hamstring grafts if soft tissue fixation is used, regarding potential tunnel effects.
So perhaps a useful alternative in certain situations. Lastly, allograft using tissue from a donor. Pros and cons.
The main advantage of allograft is avoiding harvest site morbidity altogether. This is particularly useful in revision surgeries where good autograft options might be limited, or in complex cases involving multiple ligament injuries. However, there are significant downsides. Allografts are more expensive. Biologically, they take longer to incorporate into the patient's bone tunnels compared to autografts. There's a very small but real risk of disease transmission, although rigorous screening makes this extremely rare. HIV risk is cited as less than 1 in 1.6 million. But the biggest concern highlighted in the sources, especially for young active patients, is a markedly increased risk of graft failure or re-rupture.
How much higher is that re-rupture risk with allograft in young people?
The data cited is striking. For athletes aged between 10 and 19 undergoing primary ACL reconstruction, the odds of graft re-rupture were reported to be over 4 times higher with allograft compared to using their own tissue, autograft. That's a massive difference and a major factor influencing graft choice in that population.
A very powerful statistic indeed. Does the way the allograft tissue is processed make a difference to its quality or risk?
Yes, processing methods matter. Fresh frozen allografts generally show lower re-rupture rates compared to those treated with chemicals or radiation.
Hmm.
Irradiation, used for sterilization, unfortunately weakens the graft's mechanical properties. Higher doses significantly reduce strength, and even lower doses decrease stiffness. Other methods like defreezing or certain chemical treatments might damage cells, but not significantly affect immediate strength.
So fresh frozen seems the preferred allograft type when it's used. Let's loop back to the pediatric considerations. We touched on the risk to open growth plates, freezes. How do surgeons navigate this when operating on children who are still growing?
It's a major challenge, absolutely. Injuring those active growth plates during surgery, especially by drilling large tunnels across them or using fixation methods that compress them, can potentially lead to problems like premature growth arrest, angular deformities of the leg, or differences in leg length later on.
How do they judge when a child is safe for more adult-type surgery techniques?
Skeletal maturity is key. The sources suggest onset of menstruation is often a good guide for girls nearing maturity. Generally, males aged 16 or older and females 14 or older are often considered to have mature enough growth plates to tolerate adult-type reconstruction techniques. For younger children with significantly open physes, surgeons employ specific techniques designed to either completely avoid drilling across the physis, fizzle sparing, or to minimize the risk of damaging it, fizzle respecting.
What do these growth plate-friendly techniques look like?
There are various approaches described. Some techniques keep the tunnels entirely within the ends of the bones, the epiphyses, avoiding the physis altogether. Others might cross one physis but try to do so minimally, often centrally and vertically, partial transphysial. And there are full transphysial techniques, similar to adult surgery but using smaller tunnels drilled very carefully to minimize the area of physis affected. Interestingly, the sources suggest there aren't huge differences reported in growth disturbance rates between these different specialized pediatric techniques, implying that meticulous surgical execution might be the most critical factor.
So they all carry some inherent risk, but the techniques aim to be as safe as possible. Are there techniques that involve structures outside the joint as well?
Yes, for very young children, e.g. males under 12, females under 11, sometimes combined intra-articular and extra-articular techniques are used. One example described uses a strip of the iliotibial band, ITB, from the outside of the thigh. It's harvested and routed in a way that provides stability inside the joint, but avoids drilling across the main distal femoral physis, offering stability while minimizing growth risk.
And what about graft choice specifically in children?
The sources strongly indicate that if a transfiscal technique is used, crossing the growth plate using a soft tissue graft like hamstring, carries a significantly lower risk of causing growth problems compared to using a graft with bone blocks like BPTB that pass through the physis.
What are the biggest surgical mistakes or factors that increase the risk of damaging a growth plate in kids?
The single most important factor highlighted is the diameter of the tunnels drilled across the physis. Larger tunnels obviously damage a larger percentage of the growth plate area. An 8mm tunnel might violate less than 3%, while a 12mm tunnel could affect 7–9% or more. Other risk factors include drilling tunnels at very oblique angles across the physis, using fixation devices like interference screws directly across the physis, using high-speed burrs instead of drills, adding certain extra-articular procedures, dissecting too close to sensitive growth cartilage around the joint edges, or placing sutures near the tibial tubercle growth area. Despite all care, the sources do note that some minor physical disruption, visible on imaging but not causing clinical growth problems, is reported in around 10% of pediatric ACL cases.
It really does underscore the immense care and precision needed when operating on a growing knee. Balancing stability with protecting future growth is clearly a huge consideration.
It demands significant expertise and very careful judgment, yes.
Okay, we've thoroughly covered the injury, how it's diagnosed, the decisions around surgery, the different techniques, including for children, and graft choices. Let's move now to what happens after surgery. Section 5, focusing on recovery, rehabilitation, and potential setbacks. What's the main goal right after the operation?
The overall aim of the post-op care and the entire rehab process is to safely restore the knee's normal function, stability, and movement patterns, ultimately allowing the patient to return to their desired activities, including sports, at a high level. Immediately after surgery, the focus is on managing pain and swelling. Aggressive cryotherapy using ice or specialized cold compression devices is really emphasized.
Why the big push on ice?
The sources note it significantly helps reduce pain and consequently the need for strong pain medication. Early weight bearing, as tolerated, is also generally encouraged these days. It's been linked to less pain at the front of the knee later on.
And getting that knee moving straight away is important.
Absolutely critical, especially regaining full passive extension, getting the knee completely straight passively. This should be a priority from day one. It's particularly vital if there were associated injuries like an MCL sprain or patella dislocation treated at the same time. Interestingly, the sources also mentioned that research hasn't really shown any major long-term differences between following very aggressive, accelerated rehab protocols versus more traditional, slower progressions.
So the exact speed might matter less than hitting the key milestones. What kind of exercises are typically done in the early stages of rehab? What's considered safe and what should definitely be avoided?
Early rehab focuses on activating muscles and restoring motion without putting undue stress on the healing graft. Safe bets usually include things like eccentric quadriceps. Strengthening sources suggest this can start quite early, around 3 weeks, and helps build muscle size and strength. Isometric contractions, just tensing the muscles without moving the joint, are safe for both hamstrings and quads at any angle. Gentle active range of motion, usually within a protected range like 35 to 90 degrees of flexion initially, is encouraged. Core strengthening and exercises for the hip muscles, particularly the glutes, are also fundamental from the start. But the big emphasis in early rehab, according to the sources, is on closed chain exercises.
Closed chain. What exactly are those and why are they preferred early on?
Closed chain means exercises where the foot is fixed or planted on a surface, like mini squats, leg presses, or step-ups. These exercises tend to generate compressive forces across the knee joint and are thought to put less direct shear stress on the ACL graft compared to open chain exercises. The sources specifically advise avoiding open chain quadriceps strengthening in the initial phases of rehab.
Open chain being exercises like the seated leg extension machine, where your foot moves freely in space.
Precisely. That kind of exercise, especially straightening the knee against resistance in the last 30 degrees or so, effectively mimics the forces applied during the anterior drawer and Lachman tests. It creates a significant anterior pull on the tibia, directly stressing the new graft, exactly what you want to avoid while it's healing and incorporating.
That makes perfect sense. Don't repeatedly do the movement that challenges the ligament you just fixed. Do the rules about open chain exercises change later in rehab?
This is where things get a bit more nuanced. As rehab progresses, the sources mention some updated evidence. Neuromuscular electrical stimulation, NMES, applied to the quads is highlighted as potentially beneficial, showing improvements in strength when added to standard rehab in the first few months. Regarding open kinetic chain, OKC exercises like leg extensions, some more recent research cited suggests that when introduced appropriately later in rehab, for example, after 4 weeks, perhaps initially in a limited range like 45-90 degrees, there might not be a significant detrimental effect on knee laxity, strength, or patient-reported function compared to solely sticking with closed chain exercises. This seems to hold true regardless of graft type.
That's interesting. So maybe not completely forbidden later on if done carefully. What about where rehab takes place? Is going to a physio clinic inherently better than a structured home program?
The sources suggest maybe not. Studies comparing structured, supervised physiotherapy in a clinic versus equally structured home-based rehab programs haven't consistently shown one setting to be superior in terms of long-term outcomes for strength, knee laxity, or function. This implies that the quality and consistency of the program and the patient's adherence to it might be more important than the physical location where it's performed.
That's useful information for patients, potentially offering more flexibility. Does doing rehab before the surgery, prehab, make a difference?
Yes, preoperative rehabilitation, typically involving a few weeks of targeted exercises to improve muscle strength, activation, and neuromuscular control before the operation, is shown to have benefits. The sources state it can improve patient-reported function and physical function scores in the first 3 months after surgery. However, it doesn't seem to significantly impact the ultimate time to return to sport or the overall success rate of returning.
So, it helps smooth out the early post-op phase, but doesn't necessarily speed up the final return. That brings us to the million-dollar question for many, especially athletes. When can they actually get back to playing their sport?
This is still a complex area, and the sources indicate there aren't universally agreed upon definitive criteria for timing the return to play, RTP. Historically, a common guideline was no sooner than 9 months post-op. However, the focus is increasingly shifting towards meeting objective performance-based criteria rather than just relying on time alone.
Meaning the athlete has to pass certain tests.
Exactly. Clearance is often based on passing a battery of functional tests designed to assess strength, power, balance, and control during movements that simulate the demands of their sport, things like single-leg hop tests for distance and height, agility drills, and assessment of landing mechanics.
And how they land is particularly important.
Very important. The sources specifically highlight that returning to sport while still demonstrating poor movement patterns, like that dynamic valgus knee collapse during landing or cutting, significantly increases the risk of re-rupturing the graft or tearing the ACL in the other, previously uninjured knee. Consistently, higher rates of re-injury and graft failure are reported when athletes return prematurely, before meeting appropriate functional and strength criteria.
So impatience is a major risk factor for ending up back at square one. Who makes the final call on clearance?
The decision should ideally be a collaborative one, the sources suggest, involving the surgeon, the physiotherapist, and the patient. It needs to consider not just the physical readiness demonstrated in testing, but also psychological factors. Fear of re-injury or lack of confidence can be significant barriers, even if the knee is physically strong. While the average RTP time frame is often quoted as 6 to 12 months, a crucial point raised is that the biological process of graft healing, remodeling, and maturing into a strong ligament can take much longer, potentially 18 months or more. Returning before the graft is fully mature and the neuromuscular control is restored significantly increases the risk.
That need for patience, allowing the biology to catch up, seems absolutely paramount. Now, despite best efforts, complications can still occur after ACL surgery. What are the main potential setbacks or problems mentioned in the sources?
The single most common complication reported after ACL reconstruction is loss of knee motion, leading to stiffness or arthrofibrosis. The sources strongly correlate this risk with not having achieved full range of motion before the surgery. It typically presents as difficulty fully straightening or bending the knee, and sometimes reduced mobility of the kneecap.
How do they try and prevent stiffness, and what's done if it does develop?
Prevention hinges on that preoperative range of motion, waiting for the initial inflammation to settle before operating, and diligent post-op physiotherapy emphasizing early motion, particularly extension. Aggressive icing also helps manage swelling, which can contribute to stiffness. If stiffness does become a problem, the initial approach is intensive physiotherapy, sometimes involving specific stretching techniques or serial splinting to gradually regain motion, especially within the first 3 months. If significant stiffness persists beyond that, a surgical procedure might be needed, usually an arthroscopic lysis of adhesions, where the scar tissue is released, often combined with a manipulation under anesthesia to physically push the knee through its range.
Stiffness sounds like a frustrating complication. What about problems with the graft itself? What's the most common reason for the actual reconstruction to fail?
Tunnel malposition. The sources are very clear that drilling the bone tunnels in a non-anatomical location is the leading cause of technical failure of the graft, accounting for potentially up to 70% of failures where the surgery itself is the issue. The overall graft failure rate requiring revision surgery is estimated around 5–10%, depending on the population.
And what are the consequences of those tunnels being in the wrong place?
It depends on the error. For example, if the femoral tunnel is too vertical, a common historical issue with older techniques, the graft might stop forward sliding but fail to control rotation, leading to persistent instability during pivoting a positive pivot shift test. If the tibial tunnel is too far forward, the graft can get pinched or impinged by the roof of the intercondylar notch when the knee straightens, causing pain, swelling, and potentially limiting extension or damaging the graft over time. Even small errors in placement can compromise the graft's function.
So that surgical precision we discussed is truly fundamental to avoiding the most common failure mechanism. Are there other reasons a graft might fail, besides being put in the wrong spot?
Yes, several other causes are mentioned. Fixation failure, the screws, buttons, or other devices might loosen, break, or not hold the graft securely enough. Graft tunnel mismatch can occur, for example, if a BPTB graft's bone plugs are too long for the tunnels drilled. Attritional failure might happen if the graft tissue itself was too thin or weak to begin with, e.g. a hamstring graft under 8 mm diameter. In BPTB grafts, the bone plug itself could technically dislodge within the joint. A major cause is failure to diagnose and treat associated injuries at the time of the initial surgery,
If significant damage to the PCL or posterolateral corner is missed, the ACL graft will be overloaded and likely fail over time. Improper or overly aggressive rehabilitation, particularly those open chain exercises too early, can also contribute. And certain patient factors are associated with higher failure risk, like being very young, having significant pre-existing knee hyperextension, returning to high-risk sports very quickly, or having anatomical factors like a steep posterior tibial slope.
It's clearly a complex interplay of surgical technique, biology, rehabilitation, and patient factors. What about infection after the surgery? Is that common?
Thankfully, joint infection, or septic arthritis, is a serious but relatively rare complication, occurring in less than 1% of primary ACL reconstructions according to the sources. It's usually caused by common skin bacteria like Staph epidermidis or Staph aureus. It typically shows up within the first few weeks post-op, with increasing pain, swelling, warmth, redness, and potentially systemic signs like fever.
How is an infection treated? Does it mean the graft is lost?
Diagnosis involves taking a fluid sample from the knee joint. Treatment needs to be prompt and aggressive. Usually immediate arthroscopic surgery to thoroughly wash out the joint, combined with intravenous antibiotics for an extended period, typically at least 6 weeks. The sources suggest that with this approach, especially if caught early and depending on the bacteria involved, the graft can sometimes be successfully retained. It doesn't automatically mean the reconstruction has failed, but it requires significant intervention.
So, treatable but requires swift action. Are there any other specific complications worth mentioning that appear in the sources?
Yes, a few others are listed. Infrapatellar contracture syndrome is a specific, rare type of stiffness involving scar tissue forming below the kneecap. Patellar tendon rupture or patellar fracture can occur, usually months after surgery, if a BPTB or quad tendon graft with a bone block was used. Complex regional pain syndrome, CRPS, previously known as RSD, is another potential but uncommon pain complication. Tunnel osteolysis, gradual widening of the bone tunnel seen on X-ray, can occur over time, but usually only needs monitoring unless it causes graft loosening. Long-term, the risk of developing late osteoarthritis is real, particularly if there was significant meniscus or cartilage damage initially, or in patients who are older at the time of surgery. Nerve irritation, specifically branches of the saphenous nerve near the hamstring harvest site, can cause numbness or tingling on the shin. And finally, a cyclops lesion is a nodule of scar tissue that can form in the front of the knee after surgery and physically block the last few degrees of extension, sometimes causing a noticeable click or clunk.
That's quite a comprehensive list of potential bumps in the road, reinforcing that recovery isn't always smooth sailing.
Indeed. While the overall success rate is high, surgeons and patients need to be aware of these potential issues.
Okay, let's move to our final section, Section 6, looking at the long-term outlook and injury prevention. We've already discussed the risks of not treating an ACL tear the progressive damage. What's the general prognosis with treatment, with reconstruction, according to the sources?
The sources generally portray the natural history of an untreated ACL-deficient knee as one leading toward accelerated arthritis and further joint damage due to the chronic instability. However, with a successful surgical reconstruction followed by thorough and appropriate rehabilitation, the prognosis is typically described as good. The aim is to restore knee stability and function very close to its pre-injury state, enabling a high level of return to activity in sport for most patients.
That's certainly positive news for those facing this injury and the subsequent recovery journey. Now, considering everything we've discussed, the specific ways these injuries happen, the risk factors like biomechanics and neuromuscular control, especially in female athletes, the challenges of recovery, including re-injury risk, do the sources talk much about preventing ACL tears from happening in the first place?
Yes, absolutely. Injury prevention is a significant focus in the literature reviewed, particularly prevention programs aimed at athletes, and with a specific emphasis on female athletes due to that higher risk profile we discussed. The cornerstone of these prevention strategies is neuromuscular training and plyometrics.
Neuromuscular training and plyometrics.
No,
So exercises focusing on jumping, landing, and coordination. What's the underlying principle?
Exactly. It involves specific exercises designed to improve the communication and coordination between the brain and the muscles that control the knee and hip. The goal is to retrain movement patterns, teaching athletes, for example, to land softer, with more bend at the knees and hips to absorb shock, and crucially, to avoid letting the knee collapse inwards into that risky valgus position. It also often includes strengthening exercises, particularly for the hamstrings and glutes, to improve the muscle balance around the knee and reduce quadriceps dominance.
So it's really about actively training safer ways to move to make the knee more resilient during those high-risk maneuvers. Are there other prevention tips mentioned?
For skiers, specifically, the sources mention that teaching proper falling techniques can help reduce injury risk. Regarding knee braces for prevention, the general consensus from the sources is that there's no convincing evidence that wearing a brace prevents an initial ACL injury in healthy athletes. The only potential exception mentioned is for skiers who already have an ACL deficiency, where a brace might provide some benefit.
So proactive training focused on movement quality seems far more effective than relying on external equipment for prevention.
That's certainly the message that comes through from the evidence presented in these sources.
Well, this has been an incredibly detailed exploration of ACL injuries. We've gone from the basic anatomy, the different bundles within the ligament, right through to the complex biomechanics of how tears happen, the diagnostic process, the critical decisions around surgery versus non-surgical management, the intricacies of different reconstruction techniques and grafts, the long and demanding path of rehab, potential complications, and finally, the prospects for prevention. We've really unpacked what these orthopedic resources reveal about this very common yet very significant knee injury.
I think the key takeaways are understanding those non-contact mechanisms, recognizing the risk factors, particularly around neuromuscular control and landing mechanics, appreciating why precise surgical technique is so vital if reconstruction is undertaken, and acknowledging that comprehensive evidence-based rehabilitation, including addressing psychological factors, is absolutely essential for a successful outcome.
It certainly paints a clear picture of the journey someone faces after hearing that pop, all the way through to hopefully getting back to full activity.
It highlights the biological, mechanical, and psychological challenges involved, definitely.
And if you, our listener, have found this deep dive informative and valuable, we'd be very grateful if you could take a moment to rate and share the show. It really helps more people discover these insights.
And perhaps as a final thought to leave you with, considering everything we've discussed today, the strong links between how we move, our muscle control, even our mental readiness, and both the risk of getting an ACL injury and the success of recovering from one, plus the ongoing challenge of re-injury. How much potential lies beyond just surgical repair? How might a much greater society-wide emphasis on mastering movement, implementing proactive injury prevention focused on biomechanics from a young age, and fully integrating psychological preparation into athletic development truly change the landscape for athlete health and longevity in the future?
That's a powerful question to ponder. Thank you for joining us on the deep dive for this comprehensive look at ACL injuries. We trust you leave feeling significantly more informed about this prevalent and complex issue.